Hello, everyone. First of all, thank you to Papa Postulu and Varian for having me here today. It's a big pleasure. My name is Julian, and today I will talk about TrueBeam image guidance and identified tattooless treatments. Short overview in the beginning. So I will quickly introduce me and the company I'm working for, which is called RON, but I will make it quick for time reasons. After that, I will talk about the TrueBeam system we are using in our department and the Identify system we implemented. After that, I will talk about the protocol we are using for our breast treatments using the GmbH technique. And I will show you a short example of the positioning and a short study we have lately made. So I will quickly skip that. It's not much to say here. This is a short history of our company. We started in 2008 in a small city called Aalen, which is in the south of Germany. And now over the years, we have more radiotherapy departments coming year by year. The department I'm working at came in 2020. And this year already, we have built 4 new radiotherapy departments. So you see a map of the departments here on the right side, basically in the south, west, and west of Germany. Altogether, we have 17 radiotherapy departments, 2 oncologies, and so on. I will quickly go through that again. Some Varian Cleanax, Varian TrueBeams, CyberKnife, Afterloaders, Halcyon, Artist, and so on. About the TrueBeam system, we have the TrueBeam system version 2.7 in our department. We are equipped with 6 and 15 MV photon energies, and additionally to that, we have the 6 flattening filter-free photons. For electrons, we are equipped with 6, 9, 12, and 15 mega electron volts. And most of the time, we use the IMRT and rapid arc as our standard techniques. As imaging modalities, we have the 2D, MV, and KV imaging. For the MV imaging, we have a 2.5 low dose energy. And we have the 3D KV imaging, cone beam CT, and iterative cone beam CT. So you see our treatment room here, the MV imager on the bottom here, the KV source, and the KV detector. So a few things about the iterative cone beam CT. The ICBCT uses advanced scatter correction models and iterative reconstruction methods to reduce noise, shading, and street artifacts in CBCT images. But there is no reduction in motion artifacts when ICBCT is used for reconstruction. That means it is basically recommended for static regions like pelvis and head and neck, for example. In our department, we use the 3D imaging, so CBCT or ICBCT, before every rapid arc or IMRT plans. So before we implemented the Identify system, that was our typical workflow for DIBH treatments. So first, the patient came for the CT scan, and we did markers and tattoos on the patients to mark the user origin. After that, we calculated a treatment plan. Then we did the positioning, again with the markers and tattoos. Then the imaging for validation of the positioning, and then the treatment. So our motivation to implement an SGRT system, when we decided for the Identify system, was we wanted to save some time in the different steps of the workflow. We wanted to gain better accuracy while positioning and treating the patient. And in the future, we maybe want to require less imaging and so reduce the patient's dose load. I will now talk a little bit about the basic components of the Identify system. So you have this mirrored screen here, which shows the live data of the Identify system. You have 2 of these screens. You have one in the treatment room, and you have one next to the treatment workstation. Then you have 3 of these high precision SGRT cameras. These cameras measure the patient surface at the isocenter position. Additionally to that, we have the visual coaching device. This is a device where the patient can watch his own breathing pattern, and so it's easier for the patient to know how deep the patient has to breathe in, or is it had been too deep or something like this. So that's very helpful for some of the patients to find the right threshold. And then we have these handhelds down here, which are basically for the in-room operation of the Identify system. So again, back to the treatment room, we have these 3 SGRT cameras under the ceiling up here. And additionally to that, we have the TrueBeam gating camera just underneath. So coming back to our workflow after having implemented the Identify system, we again, of course, start with a CT scan, but now we don't need any markers and tattoos anymore. Then we calculate a treatment plan. Then we do the positioning. Here again, we don't need any markers and tattoos. Then we still do the imaging for validation of the internal autonomy, basically. And then again, we start the treatment. So I will tell as an example from our breast treatments, our whole Identify workflow with the treatment from the CT scan until the treatment. So we start with 2 CT scans. We always do 1 scan in free breathing and 1 scan in deep inspiration breath hold. As you can see underneath, on the left side is a free breathing scan, on the right side is a deep inspiration breath hold scan. So as I said earlier, we don't need any markers and tattoos anymore because we are using the body surface for positioning later. Another example here where you can see again on the left side the free breathing CT scan, on the right side the GmbH scan. And the basic reason is that we want to move the heart out of the treatment field. So you can see here, we want to irradiate the thoracic wall here, and the heart is very close to it. And in this case, you have a big gap, which is much better to irradiate, so we don't have the heart in the treatment field there. So after having done these 2 CT scans, we calculate a treatment plan based on the GmbH structure set. Sometimes if we are not sure about the effect of the GmbH, or we have a patient who is not very good at breathing in or can't hold breath or whatever it could be, then we also calculate a treatment plan based on the free breathing structure. And then our oncologists decide which plan they want to apply. After having calculated these plans, we have to export our structure set to the Identify system. So in this GmbH structure set, we export the body structure and the plan isocenter. What's important for us, that we also export the free breathing structure set, because later we will use this for positioning. I will come back to that in a minute. So after having exported our calculation or our calculated plans, we have to define our region of interest. The region of interest is yellow color here. This is the area the SGRT cameras are surveilling during the positioning and treatment. So only what we define as region of interest is covered by surveillance. In our department, the therapists define the region of interest, and the therapists were especially trained by Varian trainers how to apply this region of interest for any PTV or any area we want to irradiate. So after having defined the region of interest, we come to the positioning of the patient. First of all, we position the patient in the free breathing structure, because for the patient it would be quite hard to hold breath for a few minutes. Then the patient will be out of breath before the treatment even started. So this is why I said before we have to also export the free breathing structure, because we are positioning after that. After having it positioned, having it in the initial position, we switch to the GmbH structure set. After having switched, you will then see something like this. So again, you have the region of interest here. On the right side, you have the 6 dimensions. So you have 3 translations and 3 rotations. This is the thresholds here you have defined. And in the optimal situation, everything should be right in the middle between these thresholds and shown in green color. As you can see here, you have a red bar which says the vertical deviation is quite large. Why is that? Because we switched to the GmbH structure, but the patient is still free breathing. So the system notices the patient that indicates the blue color is too far away from the SGRT cameras. So once the patient will breathe in, it will get into the threshold here. I will show you that soon. So about these thresholds on the right side, you can always change them. You can always change them for any patient according to what you want to accept as a margin. So for example, here you have 0.6 for vertical, 0.5 for the others, and so on. In our department, we usually use 0.5 centimeters for breast treatments and slightly less for prostate patients because that's much easier to position and not that movable usually. So after having done the initial setup via the Identify system, we check the internal anatomy with a TrueBeam gating CBCT. So what we do is we have a defined threshold where the patient should be breathing in, and we position the TrueBeam gating marker block on the patient's chest wall somewhere close, but in the best case out of the treatment field. And then once the patient is breathing into the threshold with a short delay, which you can also define in the settings, there will be the image acquired. In a first fraction, we always do a cone beam CT. After having acquired the cone beam CT, which is the one on the right side here, you do the usual workflow, you do the anatomical matching, and you apply your couch shifts if you have some. In the next, just for our protocol, in the next sessions, from the first day on for 1 week, we do MV-KV imaging instead of cone beam CT, just for time reasons and because it's a little bit dose load for the patients. Same procedure, so it's a gating triggered imaging acquisition. Just we use a MV beam from 0 degrees and KV from 270 to have the both dimensions imaged. If the patient is positioned well within the first week, we reduce the imaging to maybe twice a week after that, depending on how the patient is positioned during these first 5 or 6 image acquisitions. If we have verified the positioning of the patient, we then start the treatment with the TrueBeam gating. So you probably heard a lot of it already today, but I'll show you again. The yellow color means that the beam is on, that the monitor units are applied. The gray means the patient is not in the right threshold and we don't want to irradiate. Some peaks like this won't be irradiated if you set the delay for the beam on. So for example, here you see the patient has been breathing into the threshold, but you can set the delay to 1-2 seconds, whatever you like, and only after that time within the threshold, the beam will be switched on. So on the other side, on the Identify system, the screen should now look like something like this. So everything is within the threshold. You are in the deep inspiration breath hold structure set now, and you can watch the gating curve here accordingly to the TrueBeam gating. Once the patient gets out of any limits, you get a visible and audible signal and you can stop the treatment. On the next slide, I will show you a short clip of a positioning. Unfortunately, it's not a breast patient because I didn't have a video at home, but it's a prostate patient, but it's the same thing. So You can see now the patient moving into the right position. And once it is in the right position, the purple thing is turned into grayish color. And you see again red color and blue color. The red color means the patient is too close to the SGRT cameras. The blue color means it's too far away from the SGRT cameras. So you can see here, I can maybe play it again. Yeah, that you see the breathing pattern right now here. But because it's not in our region of interest, which is down here because we want to irradiate the prostate, it doesn't really matter too much to us. So you can see now everything is within the limits, and then the therapist stopped the positioning and we are ready to start the treatment. So in the end, I want to show you some small studies we did. I will quickly skip that. And we compared the differences of final online matched position and the initial couch position before the imaging. So we can see here the red bars was the positioning without identify. The green bars is the positioning with identify. So we have slightly better results, which means our initial positioning was a little bit better with identify than without. This is for prostate patients here, and we did the same thing for breast patients. So the differences here are not as big as with the prostates, but still we see we have slightly better or even much better positioning the results in different dimensions with positioning with the identify system. So at the moment, we have another study in progress because what we did before, we compared different patients to each other, which is not really the best way. And now we want to compare positioning with and without identify with the same patient. That means we do the CT scan as we did before with markers, and we also use the identify, so we have both possibilities to do the positioning. Then in the first treatment session, we do the positioning using identify, validated with imaging. Second treatment, we position via markers like we did before, verify with imaging, and so on. And we also switch between the fractures. And then in the end, we can see which positioning results were better. So we want to collect these data. We are currently doing it, 2 or 3 patients at a time. And then in the end, we can verify the results. So only a short conclusion in the end. So we have some pros, obviously, with the identify. So I think it is less stress for the patient because it doesn't need any markers which he or she has to keep for days or weeks, or even tattoos. We have equal or better positioning results with the identify. We have a slightly less time-consuming workflow that comes only with the time, because at the beginning it was very hard for the therapists to get used to positioning via identify, but that's always the same with new techniques, obviously. And for the TrueBeam, of course, it's a big advantage to have different image modalities for different treatment sites. Unfortunately, we also have some contrast. We have some limited accuracy for big and voluminous patients or very movable targets, because then, of course, for the SGRT cameras, it's quite hard to surveil the region of interest. When you have very big patients, then it's switching out of tolerance, in of tolerance all the time. That's one of the actually the only problem with very big patients. And for the ICBCT, we have a slightly longer reconstruction time for the image acquisition, which is a few seconds, but added up maybe on a whole day, it could be a few minutes, but that's only a small disadvantage, I would say. Yeah, for the perspective, our goal is to even reduce the imaging of the patients more through using the SGRT, and so reduce the patient's dose load in the future. And of course, we want to even more increase our accuracy through using the SGRT system. 20 minutes, 0 seconds. Perfect.